Okay, I would propose let's get started. A very warm welcome to this, I would call it extraordinary virtual grand rounds in radiation oncology seminar. You know our format. This is now running for about a year. We aim to present you the latest science presented by the top speakers and bringing that in an interactive format to you every first Wednesday in the month. And you recognize this is not a Wednesday, this is not the first Wednesday. So this is truly an extraordinary symposium. We try to kind of stay in our time of 30 minutes. You know that we are very grateful for the endorsement of our societies, of the Astro Society, the Swiss Radiation Oncology and the German Radiation Oncology Society. And you also know that all meetings are being recorded and you can find the prior recordings on our meeting homepage. Today, it's an absolute pleasure and honor to welcome our grand round speakers, the last one before the summer break. Professor Chris Parker, you know him for many years as one of the leading clinician scientists in the field of translation and clinical research for prostate cancer. He's consultant specialized in prostate cancer at the Royal Marsden Institute and Institute of Cancer Research in UK, London. He's former chair of the National Cancer Research Institute and the Prostate Cancer Clinical Study Group, and obviously know him from his tremendous research contributions in the field of prostate cancer research, active surveillance for localized disease, postoperative radiotherapy for locally advanced disease, and also for radium for bone metastasis. Today, we are very honored and grateful to have him here because he just published a few weeks ago in the Lancet 2, I would call it landmark clinical trials in the field of clinical treatment of prostate cancer patients, the Radicals HD trials, which tested the addition of androgen deprivation to postoperative radiotherapy in prostate cancer. Professor Parker, Chris, many thanks for joining our webinar. We're looking forward to your presentation, in particular also looking forward to the discussion thereafter. The floor is yours. Thank you.
Thank you very much, Matthias. Let me just get my slides up. So I hope you can see them. It's my pleasure today to talk to you about Radicals HD. I don't have any relevant disclosures. And at the outset, I would just like to thank my co-authors and all my colleagues and collaborators in more than 100 centres, 4 different countries, who've worked on this trial for years and years and years to the culmination of the results published just very recently. Let me start by taking you back over 20 years, because this is the design of the trial that we wanted to do. We wanted to do a randomized trial comparing adjuvant radiotherapy versus early salvage for PSA failure after radical prostatectomy. And we wanted to do this trial because there were 2 ongoing trials at the time. There was the SWOG 8794 and there was the EORTC 22911. And they were both comparing adjuvant radiotherapy versus observation. And in the observation arm, patients were not mandated to get early salvage radiotherapy. So we thought at that time that those 2 trials were bound to show a significant benefit for adjuvant radiotherapy, considering that the control arm wasn't really standard of care in 2003. Those trials were designed much earlier. So this is the trial we wanted to do, but we were faced with a problem. What to do about androgen deprivation therapy? Because some investigators wanted to use ADT with their postoperative radiotherapy. Some investigators did not want to use ADT, wanted to use radiotherapy alone. And so the way we got around that was to come up with the Radicals HD trial. And the purpose, the whole idea, was to try and avoid an imbalance in the use of ADT in the 2 arms of Radicals RT. And so, if you like, Radicals HD came along almost by accident. It wasn't our priority. And so the idea was that if you were getting postoperative radiotherapy in the Radicals RT trial, instead of mandating the use of hormones or not, we would randomize to radiotherapy alone versus radiotherapy plus 6 months, short-term hormone therapy, or radiotherapy plus 24 months, long-term hormone therapy. And our philosophy was to make this trial as simple as possible. And so here is the complete list of all the inclusion and exclusion criteria. So the idea was that if you were going to have postoperative radiotherapy, you would be eligible for Radicals HD. And everything about this trial was kept simple. The investigations, the follow-up, everything, because we wanted to recruit a very large number of patients and follow them up for a very long period of time. And we were aware that if the burden of trial work was heavy, then we wouldn't be able to manage that. So the original design was for a 3-arm randomized trial, as I showed you, but we did allow 2-arm comparisons between none versus short and between short versus long. And as you can see from the numbers, the 2-way comparisons proved much more popular than the 3-way randomization. And so we decided to report the results, analyze the results as shown here. So you can think of this as 2 separate randomized controlled trials: radiotherapy versus radiotherapy plus short-term hormone therapy, and radiotherapy plus short-term versus radiotherapy plus long-term hormone therapy. And in each of those 2 essentially separate trials, we had about 1,500 patients recruited. Now, there was a small overlap, so there's about 160 patients here who contribute to both comparisons, but it's simpler to think of them as 2 separate trials. So we set out to do one 3-way randomized trial, and we ended up with 2 2-way randomized trials. And these 2 trials were separately powered. They were independently powered in order to detect an improvement in metastasis-free survival. And the analysis was event-driven. So the analysis was triggered once the required number of MFS events had happened. And it just so happened that both trials matured at more or less the same time. And that's why they were presented and analysed all at the same time. And to emphasize that these are 2 separate trials, the patient characteristics are different. So as you can see from this slide, patients taking part in the none versus short comparison had more favorable cancer characteristics. Those taking part in the short versus long were more likely to have adverse risk factors, which is what you'd expect, no surprise. So now just a few slides summarizing the data for none versus short. So these patients were predominantly having salvage radiotherapy rather than adjuvant. They were predominantly being treated in 2 grey daily fractions, and they were almost all having prostate bed only treated. And the large majority, if they got hormones, were having an LHRH analog. The primary endpoint, metastasis-free survival, no significant difference. Hazard ratio 0.89. Now, this is an important slide because how you interpret the trial really depends what you make of this slide. So there was a significant difference in time to salvage hormone therapy. And some people have argued that this is sufficient to recommend the use of short-term hormone therapy with postoperative radiotherapy. I personally don't think that it is, but we can discuss that later. And then, of course, the trial was entirely negative when it comes to overall survival. And then the last result I'm going to show you is the pre-planned subgroup analysis. So we had hypothesized that patients might benefit more from hormone therapy if they had less comorbidity and if they had a higher pre-radiotherapy PSA. But the data didn't support that. There was no significant interaction with the treatment effect. So moving on then to the other comparison, short versus long, the patients going into this comparison were more likely to be having adjuvant radiotherapy than the none versus short, and they were more likely to have their pelvic lymph nodes treated as well as the prostate bed. In this case, the primary endpoint was positive. There was a statistically significant improvement in metastasis-free survival, a 6% absolute benefit at 10 years. And as before, there was also an advantage in terms of time to salvage hormone therapy, if you think that's an important endpoint. And once again, overall survival was not significantly different. There was a 3 percentage point difference in overall survival at 10 years. That did favour patients getting long-term rather than short-term, but it wasn't statistically significant. And the subgroup analyses, the pre-planned subgroup analyses, were similar once again. No significant interaction between the treatment effect and either comorbidity or pre-radiotherapy PSA. So the strengths of these trials, well, they're both large trials, 1,500 patients, fairly long median follow-up, representative of international practice, and importantly, will contribute to a meta-analysis, the DADSPORT meta-analysis, that's looking at all the randomized trials of hormone therapy given with postoperative radiotherapy. However, overall survival would be the ideal endpoint, but the trials are immature with respect to overall survival. MFS is not a perfect outcome measure. It may or may not turn out to be a good surrogate for overall survival. Patients in Radicals HD, some of them were getting adjuvant radiotherapy, but that's very seldom used now. And relatively few patients in Radicals HD were getting pelvic nodal radiotherapy, but that's more commonly used now after the SPORT trial. So one has to generalize the results to contemporary practice only with caution. And of course, Radicals HD was done before PSMA PET and other new imaging modalities came along. So how should we deal with patients in the clinic now in the light of the results? And I think the first thing to say is that we should wait for the DADSPORT meta-analysis rather than rely just on radicals. Here are the overall survival curves for all 4 trials that have compared postoperative radiotherapy with or without hormone therapy. And you can see that 3 of them are resoundingly negative in terms of overall survival. Only the RTOG 9601 showed a survival benefit. And so although we don't have the DADSPORT meta-analysis results, one can make a pretty good guess based on these curves. And it seems to me that given that ADT is a pretty unpleasant treatment, it has very significant morbidity, these overall survival curves are pretty underwhelming in my view. I think in order to recommend such a toxic treatment, one would really expect and hope to see a substantial survival benefit, which we don't see. So this is my rule of thumb, how I approach patients who are due to have postoperative radiotherapy after radical prostatectomy. I first of all think, do I want to treat the pelvic lymph nodes or do I want to treat the prostate bed only? And for patients with more favorable characteristics who are getting prostate bed radiotherapy alone, I recommend radiotherapy alone without hormones. On the other hand, for patients who are going to have pelvic nodal radiotherapy, the only evidence of benefit from pelvic nodal radiotherapy, the SPORT trial, mandated the use of ADT. And therefore, I would recommend ADT in patients who are getting prostate bed and pelvic radiotherapy. We can debate the duration, and I think that's very much a discussion with the individual patient. We've now got some idea of the benefit of 2 years versus 6 months. It's pretty modest, and we can discuss that benefit in the light of the downside, the morbidity, with individual patients. And so let me just close by thanking once again all those who contributed to this trial over many, many years and the funders. And I look forward to your comments and discussion.
First of all, congratulations for this huge effort, for this big success. I think it's rare that a kind of a sideline product ends up in 2 kind of very important simultaneously published trials the Lancet Oncology, and many thanks for guiding us through the slides, this data in a very short time, and also giving us an outlook on the meta-analysis. Everyone, please use the Q&A functionality if you have questions. And may I ask, may I start? So you reported for the comparison of short-term and long-term and showed that there was no differential effect based on Gleason score, margin status, not on radiotherapy schedule, timing, and type of ADT. What I was hoping for, get some idea on the PSA doubling time, which is something we at least try to consider if we see a patient in the early salvage setting. Has that been collected, the PSA doubling time in the Radicals HD trial?
Yes, I got a few backup slides in case they would be helpful. So I think the data you're referring to is shown here. So this was the other subgroup analyses, the more exploratory subgroup analyses. And looking at the short versus long comparison, none of these factors showed a significant treatment effect interaction. And with regards to PSA doubling time, of course, a significant proportion of these patients were treated in the adjuvant radiotherapy setting. And so PSA doubling time wouldn't really apply. So we've not looked specifically at patients getting salvage radiotherapy with respect to their PSA doubling time. That hasn't been done.
Mm-hmm. Another question when I was kind of asking myself and reading the publication was the grade 3 toxicity, which at least appears rather high. I think it was 19% in the long course radiation arm, and it was 13 or 14 in the short course. Was there any association with the radiotherapy volume and fractionation?
So those figures sound very high indeed, and they surprised me. So I don't have the details to hand. Do you know what specific types of toxicity were reported there? Because 19% seems remarkably high.
Grade 3, it was 18, long course, any toxicity grade 3 in the long course. Grade 1 and 2 was 59, grade 3 was 18, and grade 4 was very low 1%. And that 18% surprised me as well.
Yes. So I don't know what particular adverse effects are being picked up there. I can't believe it's radiation-related grade 3 toxicity. That wouldn't make any sense at all. So I wonder whether it's hormone therapy related or even unrelated to study treatment. I'm afraid I can't shed any light on that just now. I can delve into it after the meeting. I mean, we all have a good idea, don't we, of the toxicity of postoperative radiotherapy, and we all know it's actually extremely well tolerated, and grade 3 toxicity is very unusual. On the other hand, we also all know about the toxicity of hormone treatment, of androgen deprivation therapy, and we all know that's quite substantial.
It was a 10% urethral stricture rate, which appeared higher than I expected based on other trials before. But maybe we can also go to the questions in the chat. We have an answer for no ADT versus short-term and long-term versus short-term. What about no ADT versus long-term? Immediate question. We have almost answered it.
Yes. So the Radicals HD trial doesn't really contribute very much to that particular question. So not many patients were randomized between radiotherapy alone versus radiotherapy plus 2 years. So I don't think Radicals HD really helps us with that. I mean, the best data we've got is from RTOG 9601. So that's the only trial which really compares radiotherapy alone versus 2 years of hormone treatment. And it is interesting, isn't it? That's the only trial that shows a substantial survival benefit. So maybe if you're going to have hormone therapy, there is a rationale for giving 2 years rather than 6 months. And that is part of my thinking in the clinic. So when I have patients who are having prostate bed and nodal radiotherapy, my default is to recommend 2 years of hormone therapy.
The other kind of argument could be that the Shipley trial, I mean, the risk profile of patients was being much higher. One couldn't even call it an early salvage. There might be a benefit from PSA, but I think the cutoff was 0.7 and even stronger beyond 1.4. There are these patients which are being detected and picked up late because they drop out of kind of follow-up, but might not kind of fulfill the early salvage criteria.
Yes, I absolutely agree with that point. And I would just reiterate, I think the big picture is that the benefits of giving ADT with postoperative radiotherapy are really disappointingly small, especially weighed against the toxicity of ADT.
Obviously, there's the question of PSMA PET. Does it influence? And you already mentioned that the benefit is very small. So is PSMA PET giving any situation a stronger kind of argument to use ADT? I would say the opposite. It might kind of be more kind of driving us into a patient having a local bed recurrence where we don't have a distant metastasis, obviously. Then not going for ADT in patients having evident metastatic disease, it's different. But would a PSMA PET not being positive for metastatic disease drive you in any scenario more into an addition of ADT?
So we do get PSMA PET now as a matter of course in patients with PSA failure and a PSA of more than 0.2 after radical prostatectomy. And typically the PSMA PET is normal. And I sort of agree with you that this slightly encourages me to treat the prostate bed only without hormone therapy. Of course, there is a significant proportion of patients who have positive PSMA PET scans, and the commonest site of abnormality would be the pelvic lymph nodes. And so in that case, then I would be treating the prostate bed, the pelvic lymph nodes, and I would be giving 2 years of hormone therapy along with it. So I think the PSMA PET results are relevant in helping to decide whether to use hormones in that way.
Christian Frankhauser, many thanks for joining, a colleague from the urology, asking a urology question. So a novel urological surgical step represents fixing the peritoneum bladder after RPE again above the pelvic bone to prevent lymphosales. It seems that this step keeps the small bowel further away from the prostate bed. Is this probably beneficial regarding bowel toxicity in post-op radiotherapy setting?
Well, I'm not familiar with that approach. And I don't know the answer to the question. My sense is that postoperative radiotherapy is well tolerated. My sense is that significant bowel toxicity is actually very unusual. So I'm unconvinced whether such a surgical technique would be helpful or not.
I would share that. I was just looking again at the table for toxicity. There was hardly any bowel toxicity. So if there's no problem, it is difficult to fix it. Vice versa, I don't know the surgical technique as well, but it might also be associated with additional risk. So if it is kind of free of additional risk, maybe even beneficial from a pure surgical perspective, fine. But from a radiation oncology perspective, it's difficult, at least on the data we have, that small bowel, large bowel toxicity is a major toxicity issue in postoperative radiotherapy, where the doses of radiation are quite lower as compared to the primary setting. And even there, bowel toxicity is rather low. I have another question. Brilliant presentation. Where is it? It's now. Have you thought about analyze report metastasis-free survival at testosterone or genital levels to account this time delay bias between groups?
Yes, that's a really good question, isn't it? So we did not collect testosterone data. So this was part of the philosophy of keeping things as simple as possible. So most clinicians in routine practice in the UK at that time were not monitoring testosterone levels. And so we didn't want to impose an additional burden on them. And that's one of the limitations of metastasis-free survival, as the questioner indicates, that maybe what we're seeing in the short versus long comparison is just a delay in the detection of metastases because of the delay in testosterone recovery. after 2 years rather than 6 months treatment. So I'm not convinced that the MFS benefit that we see is actually clinically meaningful. It could just be delayed detection of metastases. That's entirely possible. And that's why I think the overall survival data are important. And the DAD-SPORT meta-analysis will really be, I think, the last word on whether or not the addition of hormone therapy improves overall survival, and if so, by how much.
You also mentioned this point quite clearly in the discussion part, where you mentioned that in the current trial population, the risk of death from prostate cancer was around 1% in 10 years. Proving a difference in oncological outcome with a 1% risk of cancer-related death will be quite challenging. One might speculate may it appear after 15 or 20 years, but I very much share this conclusion. May I ask you whether you would share that kind of interpretation? The number needed of treat in the long course arm is 16 patients. So effectively, you would require 33 years of ADT to prevent one patient developing metastatic disease, which in the end would also be treated with mostly ADT. And then we don't have an overall survival benefit. Would that be a fair kind of summary of the magnitude of benefit we can expect, or?
I think so. I mean, there are all sorts of different ways, aren't there, of expressing the magnitude of the benefit of hormone therapy in this setting. But however you express it, the magnitude is pretty modest. What I thought was interesting was the accompanying commentary in the Lancet, which written by Alan Pollock and Alan Delprat. And I thought it was excellent. I thought it was very well written, but they do come to a different conclusion to mine. So they put forward the argument that simply delaying time to secondary salvage hormone therapy is sufficiently worthwhile to recommend the use of hormone therapy with postoperative radiotherapy. And so they argue that giving 6 months, say, of hormone therapy to everybody up front is worthwhile if it prevents lifelong salvage hormone therapy in some patients further on down the line. So that is a valid argument, but I'm not convinced. And in particular, I'm not convinced because we don't know whether it does prevent lifelong salvage hormone therapy or whether it's simply delaying it because of delays in testosterone recovery. And that's why I really think there's no real substitute for overall survival as an endpoint. Anything else has limitations.
Maybe the last question, you were mentioning kind of different ways how to kind of quantify and express the potential difference or the differences. You also calculated and reported the restricted mean survival time for freedom from distant metastasis, which gives us another idea of the, I would call it benefit, but small magnitude of benefit, which was about 8.1 years in the short course and 8.7 years in the long course arm. So there is a difference, but it is less than a year.
Yes, you're right. So our statistical colleagues at the MRC, they are keen on using restricted mean survival time. And I suppose in a trial like this, where we haven't reached median survival, and we won't reach median survival for years and years and years, it does, as you say, give one an idea of estimating the potential magnitude of benefit, and it's modest.
Okay, we are perfectly on time. It's 17:30. I don't see any additional question in the chat. Chris, many thanks for joining, for in particular shedding lights in your interpretation of the clinical trials. That is what we're aiming for in this session, kind of not just showing data as they are being published, but kind of sharing your interpretation, who has spent 20 years on this study. So congratulations again. Many thanks for joining, and also many thanks for everyone for joining our seminars. I wish everyone a sunny summertime, at least here in Switzerland. We had lots of rain, now sun is coming, and hopefully everyone is enjoying some time off. Thanks again, and looking forward to meet you again in September time. There will be no virtual Grand Rounds meeting in August for obvious reasons. Let's take some time to relax. Thank you.